This is Tom, your average 21-year-old university student. He has a part-time job to help him pay bills, and he has a strong relationship with his friends and family. One evening, while hanging out with friends, Tom was hyper and talking at a rapid-fire pace, and as the night came to a close, he found himself having so much energy that he did not need to sleep. In the early hours of the morning, Tom got into his car and began racing down the freeway with nowhere to go just for the hell of it. He was high on life. For the weeks following, Tom's self-esteem was through the roof. He discussed future vacations, unrealistic financial aspirations, and a luxurious lifestyle with his friends and family. Tom even spent a large amount of money that he didn't have on items just to fulfill his version of a luxury lifestyle. And in conversation, Tom would speak a mile a minute and it was hard for anyone to get a word in. This was so out of character for Tom, as he was normally extremely subdued and calm. He was not one to lead discussion or talk about himself. Roughly a month later, Tom began to feel very low and unable to find joy in previously enjoyable activities. He stayed home often and found it hard to have motivation to complete regular activities. He didn't attend class or complete work in time, he didn't see his friends, and tried to avoid social activities. Tom wasn't sure what came over him, but all he wanted to do was be alone and sleep. At night, Tom found himself working for hours on planning a perpetual motion machine. With each blueprint he came up with, he was sure it was going to work. Tom even began actively going out and looking for sexual encounters, going as far as visiting the red light district. This was so unheard of for Tom, as he had never been that sexually driven before. So the first question is, what kind of bipolar does Tom have? Tracy here is a soccer athlete at her university. She's motivated and works hard to succeed in her passion and in school. However, Tracy feels that her mood would shift roughly every 2 weeks. For a couple of weeks, Tracy would feel motivated to practice, play games on weekends, and finish all her homework in time. She was confident in her abilities, and when she was joyous, she would get so much done and walk with her head up high. But in the next few weeks, Tracy's mood would be in a darker state. Her interests would diminish, and she would fall behind in her schoolwork. She had no motivation and no energy, and went from having no sleep to sleeping all day, yet her energy wasn't being replenished. Tracy's drastic mood became a pattern, and her moods changed bi-weekly for a long time. She would bounce between feeling low and having an abundance of energy. And her moods were not triggered by anything in particular, and they came on by themselves. Question 2 is, what kind of bipolar does Tracy have? Okay, so what is bipolar disorder? Well, it was originally called manic depressive disorder, and like its original name, bipolar disorder consists of both manic episodes and depressive episodes. There are 2 types of bipolar disorder along with a milder form. The first one is bipolar 1, and it requires at least 1 manic episode and a depressive episode to be diagnosed. And the second one is bipolar 2, which is similar but requires a hypomanic episode and a depressive episode to be diagnosed. And lastly, the milder form is called cyclothymia, which consists of hypomanic and moderate depressive symptoms. But what do these all mean and what are the differences? First, let's start off with the difference between disorder and mood. Sometimes we hear people say, "I'm so bipolar, haha," but what they're usually referring to are moods. In psychology terms, a disorder is a mental illness that causes significant impact on a person's day-to-day life. They are usually longer lasting and have higher severity. Moods are usually shorter, of less severity, and are heightened emotions due to some external stimuli. Likewise, there's a difference between an episode and symptoms. An episode is one or a series of marked occurrences with disorder-level symptoms, whereas symptoms may have long-term effects. The changed behaviors do not reach disorder-level severities, so the main difference is the severity. What about mania and depression? In simple terms, mania is like a hyper-energized self, full of energy to do anything. Yet sometimes it may break into psychosis, which is when an individual is disconnected from reality. In cases of both mania and/or psychosis, hospitalization may be required. Hypomania is a milder form of mania, so you're still energized but not as much. And depression is the polar opposite of mania, and a person with depression is a hypo-energized self, with no motivation or energy to do anything, and sometimes it may lead to suicide ideations or attempts. A milder form of depression is called dysthymia, where depression episodes are moderate but last for a very long time. It's not uncommon for people with bipolar to have major depressive disorder or dysthymia. And here's a little visual to see what different parts of bipolar would look like if it was a battery. So we have psychosis as an overload, while depression is just empty. Moving to the details, depression is the platform bipolar disorder builds upon, and the only aspect that changes between the types are the varying amounts of mania. Bipolar 1 is a manic depressive disorder accompanied with at least one severe manic episode, and these manic episodes last roughly between a few days to a couple of months. These manic episodes generally consist of decreased need for sleep, racing thoughts, rapid speech, inflated self-esteem, energetic, grandiosity, difficulty concentrating, extreme happiness or euphoria, and risky behaviors with heavy consequences such as gambling and shopping sprees. On the other hand, depressive episodes generally consist of constant depressive mood, loss of interest in most activities including the ones that previously brought joy, low energy and fatigue, feeling worthlessness or extreme guilt, decrease in appetite, and recurrent thoughts of death or suicide ideations. Bipolar 2 consists of alternating episodes of depression and hypomania, and hypomania is a less severe form of mania that has to last a minimum of 4 days for its diagnosis. Similar to bipolar type 1 and 2, cyclothymia has numerous hypomanic and depressive symptoms, but they do not meet the criteria for hypomania or depression. In order to be diagnosed with cyclothymia, the symptoms cannot meet the criteria for bipolar disorder, major depression, or another mental disorder. These symptoms have to be present 50% of the time over the past 2 years, and they cannot be brought on by drugs or alcohol. There should also be a period roughly 2 months in those 2 years where the patient is completely symptom-free. And cyclothymia doesn't have its own specific medication, but it can be treated with a combination of medication and treatments used to treat bipolar disorder. Much like other mental disorders, bipolar-related disorders have several specifiers that can be added to the overall bipolar diagnosis. There are 9 in total. The first one is anxious distress, and you have to have at least 2 of the following symptoms during the majority of the days for the most recent episode of mania, hypomania, or depression. Feeling keyed up or tense, feeling unusually restless, difficulty concentrating because of worry, fear that something awful may happen, and feeling that the individual might lose control of themselves. And all these have a level of severity, with mild with 2 symptoms, moderate with 3 symptoms, moderate to severe with 4 to 5 symptoms, and severe with 4 to 5 symptoms with motor agitation. Specifiers like these significantly help in diagnosis, as high levels of anxiety have been associated with higher suicide risk, longer duration of illness, and greater likelihood of treatment non-response. Number 2 is with mixed features, and can be applied to the current manic, hypomanic, or depressive episodes of bipolar type 1 or type 2. For manic or hypomanic episodes with mixed features, at least 3 of the following are present in majority of the days during the most recent episode. Prominent dysphoria, diminished interest or pleasure in all or most activities, psychomotor retardation nearly every day, fatigue or loss of energy, feelings of worthlessness or excessive inappropriate guilt, and recurrent thoughts of death, attempts at suicide, or specific suicide plans. As for depressive episode with mixed features, it meets the full criteria for major depressive episode, and at least 3 of the following are present for majority of the days during the most recent episode. Elevated and expressive mood, inflated self-esteem or grandiosity, more talkative than usual or pressure to keep talking, flight of ideas or subjective experience that thoughts are racing, increased energy in goal-directed activities, increased involvement in activities that have potential to cause harm, and decreased need for sleep. Number 3 is rapid cycling, with the presence of at least 4 criteria met manic, hypomanic, or depressive episodes in the previous 12 months. These episodes are demarcated by either partial or full remissions of at least 2 months, or a switch to an episode of the opposite polarity, and these episodes can occur in any order. Number 4 is with melancholic features, and at least one of the following is present during the most severe period of the current episode. Lack of pleasure in all or most activities, and lack of reactivity to usually pleasurable stimuli. You also need 3 or more of the following: a distinct quality of depressed mood characterized by profound despondency, despair, or an empty mood, depression that is regularly worse in the morning, early morning awakenings, marked psychomotor agitation or retardation, significant anorexia or weight loss, and excessive or inappropriate guilt. Number 5 is with atypical features and is present during majority of the days of your most recent major depressive episode, with mood reactivity being the main one, and you have 2 more of the following: significant weight gain or increase in appetite, hypersomnia, lead-in paralysis, and long-standing patterns of interpersonal rejection sensitivity that result in significant social or occupational impairment. Number 6 is with psychotic features. These are delusions or hallucinations that are present at any time in the episode and are split up into 2 categories: The first one's with mood congruent features. During manic episodes, the hallucination or delusions are consistent with typical manic themes of grandiosity and invulnerability, but also include themes of suspiciousness or paranoia, especially with respect to others' doubts about the individual's capabilities and accomplishments. And the second one is with mood incongruent features, and the contents of delusions or hallucinations are inconsistent with the episode's polarity themes, or the content is a mixture of mood congruent and mood incongruent themes. Number 7 is with catatonia if it is present during the manic or depressive episodes. Number 8 is with peripartum onset, which is any type of episode during pregnancy or 4 weeks after birth. And number 9 is with seasonal patterns, and it applies to a lifetime pattern of mood episodes. The essential feature is a regular seasonal pattern of at least one type of episode, while the other type of episodes do not need to follow this pattern. It doesn't count if there's a seasonal stressor, like being unemployed in the winter. It needs to be a full remission or change in poles that happen during distinct times in the year, and has to have occurred for 2 years with no non-seasonal episodes.
Today we're going to talk about the 5 misconceptions about bipolar disorder. Now the first one is that there are only manic or depressive episodes within bipolar. And that's completely false, because there are, if you remember from my old bipolar video, I talk about how people with bipolar 2 disorder never reach full-blown mania. Instead, they reach what we call hypomania, which is kind of a lower grade of mania, but it's a totally different state. It feels very different to the person, and it's just not mania. And other people don't fully reach depressive episodes. They'll just have a low-grade depression, what, if it goes on for a long time, we would call it dysthymia. And people can even, to make even more complicated and complex, people can even have mixed episodes, which is when a manic or hypomanic episode occurs at the same time as a depressive episode. And this, as you can imagine, can make us feel very uncomfortable, very frustrated and irritable, because not only do we have a ton of energy and we have a lot of these grandiose thoughts and we're very excited, but we also feel really down at the same time and very bad about ourselves, and it can make us feel very agitated, having like 2 opposites happening at the same time. And to be truthful, it gives us an increased risk for suicide, so it's something as a clinician we have to look out for. The second common misconception about bipolar disorder is that bipolar 2 is a milder form of bipolar. Now, that's completely false, because the thing about bipolar 2 disorder is that we don't reach full-blown mania, and we stay in depressive episodes for much longer periods of time. We may reach a hypomania, but because many people don't reach the mania, they never go into the hospital. Oftentimes they go years without getting help. And because depression is such a prominent part of bipolar 2 disorder, the deepness of their depression goes on for years before they get any help and they reach out for help. And it can severely impair their functioning and their ability to go to work, to interact with their loved ones, and just their overall level of functioning. The third common misconception about bipolar disorder is that people who have mood swings during the day have bipolar. People will often say, oh, you know, she's on it again. She's so bipolar. Mood swings are not bipolar disorder. If you remember in my video back in the day that I talked about bipolar disorder and how we diagnose it, in order to be diagnosed with bipolar disorder, whether it's 1 or 2, now in 1 we have to reach full-blown mania. That means that we have this grandiose sense of self, this extreme feeling of elation, and mania has to occur for at least 1 week, and those symptoms have to permeate each of those days almost completely, meaning there's no real breaks. We feel this way continuously for a week. And in order to be diagnosed with a major depressive episode, if we had bipolar 2, if we'd never reached mania and we had a depressive episode, in order to get that, we have to be in a depressive episode, meeting at least 5 of the depressive criteria, and it has to last for at least 2 weeks. So you can see that someone's mood shifting during the day is definitely not bipolar disorder. Those are just mood swings. The fourth common misconception about bipolar disorder is that all bipolar patients have mania. And as you remember from my old video and what I talked about previously, that's not true, because bipolar 2 patients never reach full-blown mania. They reach hypomania, a lower grade version of mania, And they spend a lot of their time, I'd almost venture to say a majority of their time, in depressive episodes. Therefore, not all bipolar patients have mania. The fifth common misconception about bipolar disorder is that those who've been diagnosed with bipolar are unreliable or can't function. Now, you and I both know that that is completely untrue. That's a false accusation. People who have mental illness are not hindered. We can overcome. If we get the help and the support that we need, we can do whatever we want. Just because we're diagnosed with bipolar disorder doesn't mean that we can't achieve great things. Many people who have bipolar disorder are doing wonderful things in our world. They are actors and actresses, business owners, they're artists, they're doing whatever they want. So don't think that having a diagnosis means that you can't do what you want. I just encourage each of you to reach out and get the support and the help that you need in order to function in your life and do whatever it is you dream to do. Because we can all do what we dream, right?
When it comes to the prevalence rates, roughly 1% of Canadians meet the criteria for bipolar disorder, which is around 380,000 people, while in the US, 2.8% of the population meet the criteria, but that's almost 3.3 million people. Now that's a lot of depression. When it comes to comorbidity, according to the DSM-5, bipolar 1 co-occurs the most with anxiety disorders, affecting 75% of those with bipolar 1. Over half the individuals have reported having ADHD, conduct disorders, and substance use disorders. Unfortunately, adults have high rates of serious and untreated conditions, with metabolic syndrome and migraines being more common in bipolar diagnosed people than the general population, and not to mention they have higher chances of suicide. As for bipolar 2, 75% of them have anxiety, 37% have substance use. Children and adolescents have a higher rate of anxiety disorders compared to bipolar 1, with anxiety normally predating the bipolar disorder. 14% of them have at least one lifetime eating disorder, such as binge eating, which is the most common, and anxiety and eating disorders are more common during depression, while substance use is more common with mania. And as for cyclothymia, substance-related disorders and sleep disorders may be present, and children are more likely to have ADHD as well. The impact of having anxiety disorders with bipolar disorder is quite intense. The first one is increased symptom burden, and that includes increased psychological distress, increased irritability, greater severity of acute episodes, and a greater burden of both manic and depressive symptoms. The greater severity of mood episodes is also reflected by the longer durations of these episodes, particularly depressive ones. And there are higher rates of chronicity in bipolar disorder because of those anxiety disorders. We also have poorer remission and recovery. Patients have been found to have significantly longer times to remission, shorter remissions, and less likelihood of achieving complete recovery. We also have persistence of subsyndromal symptoms, greater risk of developing an early relapse, and higher risk for hospitalizations. They also have overall greater functional impairments and poorer quality of life than those without this comorbidity. Unfortunately, studies showed that the comorbidity also results in inadequate treatment response, getting delayed diagnosis and institution of treatment, more severe medication side effects, non-adherence with treatment, increased healthcare utilization, and increased costs of care, which can be detrimental. And lastly, there's elevated suicidal risk. A large meta-analysis of suicidal risk in bipolar disorder found that comorbid anxiety disorders were strongly associated with suicide attempts. Similar increases in suicide risk have been reported among other comorbid anxiety disorders, including GAD, PTSD, OCD, and social phobia. The elevated risk of suicide has been proposed to be the result of increased illness severity, greater depressive symptom burden, additional substance use disorder comorbidity, the presence of comorbid personality disorders, and several maladaptive traits such as impulsivity or neuroticism. We took a look at a meta-analysis to look at the neurological differences of people with bipolar disorder. What we found is that neural models of bipolar disorder suggests a role of frontal limbic disconnectivity. And functional MRI scans have shown that the emotional instability might exist because of that abnormal connectivity between the two systems. DTI studies have also shown us that more extensive brain abnormalities exist in bipolar disorder. In the largest bipolar DTI study to date, they found alterations of white matter microstructure along multiple bundles with the strongest effect within the corpus callosum and the cingulum. The primary function of the corpus callosum is to integrate motor, sensory, and cognitive performances between the cerebral cortex on one side of the brain to the same region on the other side, and reduction in this has been implicated in schizophrenia and depression as well. This suggests an overlapping involvement in both psychosis and affective disorders. As for the cingulum, it projects from the cingulate gyrus to the entorhinal cortex, allowing for communication between components of the limbic system. It has been linked with emotion, memory, and attention, as well as visual and spatial skills. The cingulum is very important for connectivity and the integration of information between areas of the brain. There have also been findings that the anterior superior longitudinal fasciculus is also smaller in people with bipolar disorder. It connects the frontal lobe, occipital lobe, parietal lobe, and temporal lobes. But overall, they have not found any kind of significant difference between bipolar disorder type 1 and type 2. Another study showed that individuals with bipolar 1 who have attempted suicide showed greater gray matter volume in the right rostral anterior cingulate cortex compared to bipolar disorder people who had not attempted suicide. The anterior cingulate cortex has been linked to involvement in certain higher level functions such as attention allocation, reward anticipation, decision making, ethics and morality, impulse control, and emotion. It has been shown that the anterior cingulate cortex increases in size during moments of mania, but decreases during depression, and it's believed that the emotional section of the anterior cingulate cortex is overactivated, while the cognitive part is underactivated. The orbital frontal cortex and insula have also shown differences between bipolar people who have attempted suicide and those with bipolar who have not, with both of these areas having increased in size. The orbital frontal cortex seems to be related to emotional processing, including the expectation of reward and punishment, risk decision making, and impulse control. The insular cortex is considered a limbic integration area, and in bipolar disorder, it is involved in emotional processing and mood regulation. Overall, we can see a large amount of involvement of the limbic system as well as its connectivity to the frontal lobe in bipolar disorder. This makes sense as bipolar disorder is a disorder that consists of two emotional extremes. The fact that brain structures appear to change during times of mania and depression is a very good indicator why someone may experience such different extreme states.
Understanding bipolar disorder. Bipolar disorder encompasses a wide spectrum of symptoms and is classified according to the types of mood episodes exhibited, including manic, hypomanic, major depressive, and mixed episodes. Bipolar 1 disorder involves a manic or mixed episode in contrast to bipolar 2 disorder, which involves at least one major depressive episode and at least one hypomanic episode, but no full manic or mixed episodes. Bipolar disorder should be differentiated from major depressive disorder, or MDD, which is diagnosed when a patient experiences one or more major depressive episodes without any lifetime episodes of hypomania or mania. Depicted here is a life chart or mood chart, which follows the patient's lifetime history of mood episodes. This permits the identification of mood episodes that are the most prevalent and important to prevent. In this patient, as with many patients with bipolar disorder, depressive episodes become the more prominent aspect of the illness as the person ages. Several morphometric differences have been observed in the brains of bipolar disorder patients relative to healthy subjects. White matter hyperintensities and reduction in gray matter volume, identified with MRI, have been described in patients with BPD. Increased ventricular size and decreased frontal cortical area volumes may also be observed in BPD patients. The pathophysiology of bipolar disorder encompasses environmental, behavioral, neuronal, cellular, and molecular levels. At the molecular level, aberrant signaling cascades alter synaptic plasticity. Strong evidence supporting the importance of second messenger signaling has come from studying the targets of mood-stabilizing drugs such as lithium. GSK3 and IP3 signaling cascades are known to mediate axonogenesis, synaptogenesis, neuronal growth, and cone spreading. Other downstream effects may also be involved. The heritability of bipolar disorder is around 80%. Monozygotic twins are reported to have a higher incidence of developing bipolar disorder, approximately 40%, whereas the incidence is only 10% in dizygotic twins. Although the process of developing bipolar disorder likely arises from complex interactions between genes and environmental factors, the specific genes that contribute to this risk are not known with certainty. Variations of several genes have been identified as potential contributors to the pathophysiology of bipolar disorder. Among the identified genes are those associated with serotonin signaling, SLC6A4, TPH2, dopamine signaling, SLC6A3, DRD4, glutamate transmission, DAOA, DTNBP1, and cell maintenance and growth, NRG1, BDNF, DISC1. The most significant environmental triggers of mood episodes among patients with bipolar disorder include use of drugs with mood-altering properties, changes in circadian rhythm, and life stressors. Successful management of bipolar disorder requires particular attention to minimizing the effects of these influences.
As for family treatment, a study was done by Fisher and colleagues in 2018 where they used decision aids to help families make decisions for treatment. It follows the Patient Decision Aid Standards, which is an informational document that lays out different treatment options, risks, benefits, and overcomes for non-adherence or adherence, while providing additional resources and information on bipolar disorders. Other studies looking at family structures found that for adolescents with bipolar, developing better problem-solving skills and constructive feedback were correlated with better family dynamics. Additionally, families had lower cases of hospitalization, no comorbidity with personality disorders, more autonomy, higher cohesion, and more recreational activities. But we also use regular medication to treat bipolar disorder, most commonly antidepressants, antipsychotics, mood stimulants, and anti-anxiety meds. Starting with antidepressants, there are three main categories: SSRIs as the starter, tricyclics as the second strongest, and monoamine oxidase inhibitors, which has the strongest effects. And a lot of the treatment is off-label use because doctors prescribe them to patients for the side effects. There's also electroconvulsive therapy, but that is the last approach when it comes to treating an extreme form of depression. Moving to antipsychotic medication, it's basically a major tranquilizer. There have been 3 levels separated by 3 generations. The second generation medication are atypicals, which is the first step to treating psychosis. It's utilized the most often and is very effective and is often used off-label because of the sedating effects it has on its patients. The first generation medication are called conventionals and are used if there's no response from the atypicals. They are strong meds and act really fast. They work best with patients who have extreme forms of manias such as yelling and screaming. Conventionals such as clozapine are considered the last resort because it can have a fatal side effect, and if used, patients need to be closely monitored. Mood stabilizers such as lithium are one of the most widely used and studied medications for treating bipolar disorder. Lithium acts on a person's central nervous system, and doctors don't know exactly how lithium works to stabilize a person's mood. But it is thought to help strengthen nerve cell connections in brain regions that are involved in regulating mood, thinking, and behavior. It's one of the best medicines out there for bipolar disorder, but it has a small window when it comes to its therapeutic dose and lethal dose. But it does work wonders to boost the mood and enables patients to enjoy participating in their favorite activities again. Bipolar disorder definitely requires long-term treatment. Since bipolar disorder is a chronic, relapsing illness, it's important to continue treatment even when you're feeling better. Most people with bipolar disorder need medication to prevent new episodes and stay symptom-free. But there's more to treatment than just medication. Medication alone is usually not enough to fully control the symptoms of bipolar disorder. The most effective treatment strategy for bipolar disorder involves a combination of medication, therapy, lifestyle changes, and social support.
Bipolar disorder is treated with medication and with specific psychological interventions. In terms of medication, the most common treatment is also the oldest one, and that's treatment with lithium salts. And this has actually been the primary treatment for bipolar disorder for the last 50 years. And that's because it's still the most effective treatment that we have. It's still the most effective at managing manic episodes. But as it turns out, researchers still aren't 100% certain why it's so effective. They're not certain about how it works on the neuronal level. One theory is that lithium enhances serotonin release by increasing production of the components that make up serotonin, or maybe that it increases serotonin release in other ways. But there are also theories that focus on other neurotransmitters. So there are some theories that say that lithium enhances the reuptake of norepinephrine, and in doing so, it would decrease the effect of norepinephrine over time. There are other theories that state that lithium actually exerts its effects on areas of the neuron other than the synapse. So one theory is that it influences the sodium channels along the axon, the ones that help move the action potential down the neuron. And who knows? Maybe in a year or two, research will lead us to a newer, more accurate hypothesis, and then I will have to remake this video. But for the time being, know that whatever the mechanism is, it is a very effective mood stabilizer. It has other things going for it as well. It's also relatively fast-acting, so it starts to work in as little as 1 to 2 weeks. And it also avoids some of the worst side effects that we might see in other bipolar medications. Specifically, it doesn't bring about a depressive episode or cause general sedation. And you can see why this might be a concern for bipolar medications. That in bringing people down from mania, they could inadvertently push them too far down, or too far in the other direction. But with that said, lithium does have other side effects. The first one I want to talk about isn't so much a side effect as it is a problem with mood stabilizers more generally. And that's that individuals sometimes treat lithium the same way that they might treat medications for a headache. So if you have a headache, you might take something to make it go away, and once you feel better, you don't take any more of the drug. But lithium, and also other mood stabilizers, they don't work this way. Individuals need to keep taking them for the medication to be effective. They can't just stop taking them once they feel better. In terms of side effects of taking lithium specifically, a big one is the effect that lithium can have on memory. It can cause memory loss and can also cause problems with creating new memories. Another side effect is that lithium can sometimes blunt normal mood changes, and this can lead to a huge decrease in quality of life. So imagine not being able to feel happy at your own birthday party, or not feeling sad when a partner loses a job. These kinds of mood changes are a part of everyday life, and it's very apparent to people when they're missing. Some individuals might also be hesitant to give up their manic episodes because they see them as something positive. Even though they can be incredibly destructive, they can also increase a person's productivity and their creativity. So individuals might be resistant to taking medication to stop something that they don't believe is a problem. But maybe the biggest side effect of lithium has to do with toxicity. Lithium can affect kidney and thyroid functioning, and this can become even worse when a person is dehydrated, which is something that lithium itself causes. So individuals who take it have to be very careful about staying hydrated at all times, even more so than the rest of us. And because of this toxicity problem, people taking lithium need to be carefully monitored by doctors. The last side effect I want to talk about isn't really a side effect at all. It is actually more of a limitation. And that's that lithium doesn't treat depressive episodes. So it helps with mania, but it doesn't help with the depression part of bipolar disorder. And because of this, individuals taking lithium generally have to take an antidepressant as well. And this can lead to two problems. One is that some antidepressants, like SSRIs, which are the most common treatment for depression, they can actually trigger manic episodes for some individuals with bipolar disorder. And so this can limit treatment options. And the second point is that in addition to the side effects from lithium, the patient will also have to deal with any side effects for this additional antidepressant. I want to point out that there are some other medications that people are using to treat bipolar disorder. There has been some success with treatments that involve anticonvulsants and antipsychotics, and also some benzodiazepines. But at least in the short term, like I said before, lithium is still the preferred treatment. So now I want to move on to talk about psychological treatments. And you might remember from your psychology class or from other videos in this series that there are some psychological interventions that are very effective for treating major depressive disorder, sometimes as effective as medication. But the same is not true of bipolar disorder. Psychotherapy in all forms, from psychodynamic therapies to more modern forms of psychotherapy, they are not effective in treating bipolar disorder. Talking about bipolar disorder and trying to find the cause isn't very helpful for this disorder. One type of therapy that is very effective in treating depression is CBT, or cognitive behavioral therapy. And this type of therapy addresses problematic thoughts and behaviors. So it's a very action-oriented therapy. But even though it is effective in treating depressive symptoms of bipolar disorder, it is not effective in treating manic episodes. But even if these psychological interventions don't help treat the symptoms of bipolar disorder directly, they can still be a very important part of the treatment for bipolar disorder more broadly. For example, CBT can provide support for an individual after a manic phase has ended, so it can help them to fix the social and financial situations that might have been brought about from their manic episode. But it turns out that the most effective type of therapy for bipolar disorder is actually family therapy. There's a lot of research that shows that stressful situations can trigger manic episodes for individuals with bipolar disorder. And we know that this is especially true for social stressors. And because living with someone with bipolar disorder might be stressful for the family, that family might sometimes inadvertently be triggering for the individual with that disorder. And so it turns out that one of the best ways to manage bipolar disorder, both short-term and long-term, is by providing the family with the tools necessary to help them provide support and to help them provide a stable home environment.
Oftentimes, when we speak about mental health disorder, the focus is mainly on the individual. While it is important to understand the impact it has on that person, it is also critical to examine the person's environment. Research has shown that family and social support structures are vital to the well-being of any individuals living with bipolar disorder. And just like any other illnesses or disorders, taking care of someone takes a huge amount of energy and time. Some common struggles and frustrations mentioned by caretakers of people with bipolar were changes in their work and life schedules, financial burdens with treatment and medication, or the loss of an income provider, the lack of sharing in family responsibilities with caretaking, stigma within the family and disbelief of illness, and the worries of the individual's future in regards to jobs, marriage, health, and overall trying to become a more self-sustaining individual. Unfortunately, the family members themselves also have burdens and thoughts on themselves too. In fact, a study by Rayners and colleagues in 2016 reported that caretakers were more likely to be depressed, akin to clinical depression. Here are some feelings from the caretakers themselves. They had a fear of having a mental disorder in the future. They had thoughts of unforeseen events preventing caretakers to continue supporting family members. Language barriers and cultural differences in understanding disorders can also be an issue, such as using non-Western medication, religious rituals, and misunderstanding mental health in general and downplaying it as weak emotional control. They get overwhelmed with responsibilities, such as making all the decisions and having more work in general, and they have no one to talk to about their burdens and no one understands their struggles. Thankfully, there are social improvements for caretakers and their families can improve family function and reduce tension among them. And we'll end the video off with the prognosis. Bipolar disorder is not curable, but there are many treatments and strategies that a person can use to manage their symptoms. Without treatment, bipolar disorder may cause unusual mood episodes, and people with the condition may alternate between high periods called manic episodes and low periods or depressive episodes, and it's important to ensure the correct treatment plan is right for you.
Living with bipolar illness, I think it makes me a better psychiatrist. When someone comes to me with something, I don't only know it intellectually, I know it through a lived experience. There are times where I can feel that the patient would benefit from maybe knowing that I really understand what they're going through. But I think right now, unfortunately, within medicine and even within psychiatry, stigma still does exist. I'm hoping that maybe one day I will be able to be more open about it. Because it does feel like I can't really share a big part of myself that could potentially benefit someone else, right? Or give them hope. I had this great life, I was in medical school, I had great friends, I had a great family, and I had a certain vision of what my future was going to be. When I first experienced my first episode, the psychiatrist felt that I needed an antipsychotic medication. And that moment was like, it's almost like the carpet was pulled from under my feet. Kind of saw myself as, like less than and mentally ill. I really felt the stigma. I had a hard time looking people in the eyes and facing friends. People were talking about, oh, when you get better. And I would look at them like, when I get better, what are you talking about? This is how I'm going to be for the rest of my life. I was thinking I'm never going to return to school. This is never going to get better. And you're also sort of grieving that amazing life that you thought that you were going to have, and all of a sudden it's gone. The first depression that I experienced was very, very severe. I had to take a year off school. I spent most of my time like in bed, and my family had to literally come and like peel me out of bed off the floor. All I could think about was just dying. Every moment was just agony. Like every moment felt like an eternity. Just feeling like I'm hopeless. Like I'm never gonna get better. My life is over. When I kind of lost faith in myself, I had several friends just regularly calling me, and they would just remind me, we love you, we're here for you, this is who you are. But I was thinking about all these ways that I would end my life. I never attempted. The only thing that kept me alive was I could not hurt my family and my friends. I just couldn't. When I started the recovery process, never in a million years did I think that I was gonna come back to school. I never thought that I was gonna get married. I didn't think that I would have a family. It was a good year and a half until finally we found the right combination of medications, and until I really fully recovered and started to feel fully like myself. The number one most important thing in my recovery is the people around me. I have a really amazing and supportive husband, really, incredible parents-in-law, a very strong friend network. Everyone knows about, my illness, and they're very open with me. Thankfully, I haven't experienced a depression in years, but I definitely do fear it. It's not like at the forefront of my mind, but because of that, I do everything I can to prevent it. I try to keep it in perspective. Okay, it's part of who I am, but it doesn't define me. It affects me, but it doesn't define me.